cabbage. So I'm just going to kind of give a broad overview in terms of the lay of the land. These are my disclosures, haven't changed since this morning. So conservative therapy versus revascularization, so no randomized controlled trials. So all the information is based on experience and expert opinion. In general, as we've heard many times, conservative management is preferred, and this is because these dissected vessels will generally heal, as we've heard and seen. And there is a high rate of complications and failures with revascularization. There are certain situations that revascularization appears to be needed, and this could be PCI, which is going to be where you have stents, or cabbage, where you have bypass surgery. And these are situations where the person has ongoing ischemia, they have cardiogenic shock, they have a left main dissection or proximal to vessel disease, or they're hemodynamically or electrically unstable. And then cabbage is ultimately reserved for patients that have left main dissection or in whom PCI either can't be done or was attempted and was unsuccessful. Having said that, that we typically do conservative therapy. Conservative patients will often, or not often, sometimes go on and have some issues. So 3 to 10% of those who are conservatively managed will have a recurrent MI or require urgent revascularization or have some other MACE event during their hospital stay. So we do have to monitor these patients closely. And ultimately, the decision whether you're going to do conservative therapy or revascularization and what type is going to be made on an individual basis. It's going to be based on the anatomy you're dealing with, the stability of the patient, and then the expertise of the operator and or the center. So I'm going to cover challenges with these modes of revascularization, and then you're going to hear about kind of strategies to overcome those challenges and ultimately outcomes with these strategies. So challenges with PCI, so the failure rate's actually quite high with SCAD patients. So reported, and I should say there's multiple studies, I listed several of these that have looked at this with PCI and cabbage. So failure rate's 27% to 50%, which is incredibly high compared to what we would have when we're just doing PCI on patients who have regular atherosclerotic disease. There is this risk of iatrogenic catheter or wire-induced dissection, so this is when the operator causes a problem. I would say it's probably higher. I know this is what we have reported in the literature, but certainly the cases that we get into Stanford that are from the outside, we see this all the time, that the catheters dissected something or the wires dissected something. And a lot of it is because the operator had no clue that it was a SCAD to begin with, or they weren't suspecting it, and so didn't use appropriate caution. And also, even when you do use appropriate caution, though, these things can happen. I think all of us in the cath lab, knowing we even had a SCAD, have still had complications like this. Patients who have an iatrogenic dissection do have a higher in-hospital MACE rate, 25% compared to 5.5% than those who didn't have something like that happen in the cath lab. With PCI, you're going to see extension of the dissection quite frequently, so 25 to 60% of patients, and the dissection could go down the vessel, it could go up the vessel, it could go outside vessels. So it can spread around and can be very difficult to chase. I would say SCAD is the scariest thing that we see in the cath lab because it's very unpredictable. It doesn't do what you want it to do, it does what it wants to do. So with PCI, 9 to 13% will require urgent cabbage. This again is not at all what we would see with regular atherosclerosis. In the old days, you used to have surgery on standby, and that's completely unheard of. We have lots of centers in the United States where they don't even have surgery back up. So this is a high rate of needing urgent bypass surgery. 30% of these patients will have TBR, which is target vessel revascularization, meaning that the vessel that we worked on needs further work at 5 years. Stent thrombosis, getting a clot in your stent, that's 6% of patients, again, well above what we would typically see with atherosclerotic disease. In addition, this intramural hematoma can really kind of make it hard to understand how big is this vessel actually. And as that resorbs, the stent may have been undersized, and so it could be the stent's kind of hanging out now in a vessel that's actually much bigger once that clot gets resorbed. or the vessel may have just looked small angiographically and an undersized stent was placed. An undersized stent or malposed stent increases the risk of stent thrombosis and also the risk of in-stent restenosis. So the in-hospital MACE rates are lower with conservative therapy versus revascularization, but as mentioned, conservative therapy doesn't mean you're out of the woods either, and you certainly have to, again, watch these patients. About 10% are going to need something or be going back to the cath lab. So challenges with CABG, so Dr. Price is going to talk about this if you ask a surgeon. But in fact, maybe there's some. So there is always a standard risk with CABG. However, when we look at the SCAD patients who have had CABG, they have generally had excellent in-hospital outcomes, high rates of technical success, and very minimal terms of mortality. It can be challenging for the operator or the surgeon to isolate the suitable graft insertion sites. You can imagine if you have these different layers, can you find a spot where the layers are all back together, which would be an ideal place to put the graft, and if not, can you actually put those layers back together yourself? And that can be hard. This TBR, so target vessel revascularization rate, again, is 38% with CABG. And there's also a lot of failure with these grafts in the long term. So a series out of Mayo showed that 11 of 16 grafts were occluded at long term. Probably this actually isn't a problem, it is probably a result of the fact that these vessels have actually healed. So grafts need good flow through them to stay open, and if your vessel heals, your flow is going back through your normal vessel, and that graft isn't getting all that blood flow, and it can close. So the way I often think of these bypass grafts is they're temporizing, so they get people through the acute phase, allow their own vessel to heal, and then they kind of fade into the background. Because of that, it's typically probably a good idea to use grafts that are taken from the veins, because arterial grafts like the lima are grafts that we really want to preserve if we can. If you ever needed bypass surgery for an actual plaque in the future, that's a graft you want, and veins are a little bit more disposable. So CABG isn't protected against recurrent SCAD, nor is PCI actually. So there's always that risk. It tends to be in a different vessel, however. So there's a nice algorithm that Jackie put out a couple of years ago, and I think this has kind of given people some guidelines on how to take care of patients. So I'm going to go through this, and then I'll close with this. So basically, if you have a stable patient, let's see, there's a pointer, right? So if you have a stable patient and they are doing fine, then conservative management, and this will be a lot of the patients. If they have some high-risk feature, then you're going to have to think about what are we going to do. If they're in cardiogenic shock or have a ventricular arrhythmia, and this is making them unstable, then you're going to probably need some sort of support, so left ventricular assistance device, or ECMO, or they might need a defibrillator, has been talked about. And if they're unstable because of their coronary issue, then they're probably going to need their coronary fixed. If it's something that you can fix with PCI, then you'll probably go ahead and fix it, although again, it may start to go in this spiral of you're fixing it and it looks worse and it looks worse, but you do the best you can with it. If it's a left main, this can be a little bit different, right? So this applies the entire left coronary circulation. If it's kind of an easy left main, which would be at the beginning, the ostial left main, or in the mid shaft of the left main, this usually requires one stent. PCI is a reasonable option. If it's more complex, so it's involving the distal bifurcation and into the proximal vessels that of the LAD and the circumflex, then you're going to have to start thinking about would bypass be better here, particularly if that's all dissected, but the distal vessels look like they're not dissected and a graft could go on those easily. When you have this situation, there are some patients that will have a left main and even proximal vessels, but they're actually relatively stable. Some have advocated that you should go ahead and still have them do CABG just in case they become unstable, because left mains, if you become unstable, you could quickly have a But there are other patients where they have a left main and you can actually watch them and they'll do fine. We had a patient, gosh, only a few weeks ago, I guess it's now been over a month, but I was not around. And it's interesting how people at your institution kind of decide how to take care of SCAD patients based on little bits they heard. But this woman came in and they got just a CT and they saw she had a left main dissection. And so then they just decided to watch it. And I was like, wow. Which it seemed like everybody's really feeling comfortable with SCAD now. But so she didn't get an angiogram and they didn't do anything. And so I heard about this afterward and I actually saw her in clinic and she did perfectly fine. It actually had gone, it was in the LAD as well, so it's actually a big dissection. But it is possible that if you have a left main involving proximal vessels, that these patients can be watched, but obviously watched closely because of the risk of extension that we talked about. So a lot of this really is going to require a lot of judgment, paying close attention to these patients. The more we see patients, the better we understand how they might act, but everybody is different, so that's important as well, of being attentive to that. So we're going to go on then and have, Jackie's going to now talk about PCI and kind of strategies to overcome those problems that I showed, and then we'll do CAD after that. Thank you.